muchas gracias. Creo que es mejor en inglés, no en español. What about this topic? We have to remember, first of all, the cause of the liver failure. We have acute liver failure that has a pathophysiology different from acute or chronic liver failure, because one is more severe, and the other one is most inflammatory response that give the acute or chronic liver failure. But in both, we have the indication and we see the use of extracorporeal liver support. We have to remember that there are several distinctions in acute or chronic liver failure, and we have some grades of the syndrome. And of course, the more the liver of the failure of the organs, the more is the mortality. And so we have focused our attention on the 3 and the 4 grade of acute liver failure, in which the patients are very, very severe condition. We have to remember that in liver surgery, we have 2 kinds of liver surgery, of course, that is the hepatectomy and the liver transplantation, but in both of these scenarios, we can have the liver failure, and in the first one is the post-hepatectomy liver failure, that is the same for the transplantation, in which we have the small for size liver failure after the transplantation. But in both sides, we have a liver that is not enough for that patient. We remember, of course, that the indication of the hepatectomy is the treatment of primary tumors or metastasis of the liver, of course. And we have to remember that there are some different definitions of the post-hepatectomy liver failure. One of these is the 50-50 criteria. On day 5 post-hepatectomy, if we have the reduction of the PT less to the 50%, and the increase of the bilirubin then more than 2.9 milligrams per deciliter, we have the definition of a post-hepatectomy liver failure. And we observe that this kind of syndrome has a great mortality, because it's up to 60% of mortality of this patient. And we observe that even the bilirubin per se is a factor of that can give us the indication that the patient can die more than who has not the post-hepatectomy liver failure, of course. That it's not so common, but it's very, very severe in this kind of patient. And we have different grades of this liver failure, and of course the indication to use the extracorporeal liver support is in the grade C, in which this patient goes to ICU, and so we started the intensive treatment as extracorporeal liver support. We have to remember that in all the surgery we have an inflammatory response in the patient, of course, and we have to remember that during the hepatectomy, the vascular alteration of the portal flow, if is enough, can induce the regeneration of the liver. But if you cut too much liver, too much mass of the liver, the augmented pressure is too much and reduce the regeneration of the liver. And we have to remember even the ischemia reperfusion, that it's a problem of all the surgery, because we induce ischemia of the tissue. And so we have the release of inflammatory protein and of course the production of oxygen reagents. We have to remember the cytokines, that it's an inflammatory response to the surgery, and the activation of the complement, in particular the subunit C4A, that it's a great induction of the inflammatory in this patient. Of course, we have to remember that the condition pre-hepatectomy or transplantation can give us the augmented possibility to have post-hepatectomy liver failure, of course, like steatosis or cirrhosis, of course. We have to remember that in a normal liver we can have the remnant liver, future liver remnant, that is the quantity of the mass of the liver after the surgery, that in a normal liver can go up to the 20% of the original mass of the liver. But if we have a steatosic or cirrhotic liver, we have to preserve up to 40%. Otherwise, you go to the post-hepatitis liver failure because the rental liver is not sufficient to the patient. And we have other situations in which we go to the post-hepatitis liver failure. Of course, as we said before, the maneuvers of occlusion of the vessel of the liver, of course, give an ischemia reperfusion. But even the massive bleeding, more than 1 liter, of course, cause ischemia due to hypotension of the liver, and so we have to go to the post-hepatectomy liver failure even in this case. Of course, another complication can be the sepsis, because we reduce, of course, the circulation, we reduce the mid-arterial pressure, so we give hypotension even to the gut, and we have translocation of the bacteria to the blood of the patient, and it's not so good, of course, as a complication. We have to remember that even in transplantation we can have this kind of situation that are defined the primary graft dysfunction after the transplantation, that can be initially poor function or primary non-function. The initially poor function is quite reversible, otherwise the primary non-function in many cases required on retransplantation of this patient, of course. And so we have some papers that use this kind of absorption after the transplantation to avoid the retransplantation on the patient, removing the cytokines and the toxin after the transplantation of the first graft in this patient. And which are the indication to use extracorporeal support are, of course, all the liver failure, acute or chronic, of course, the liver failure of the sepsis, the pruritus, but we have even indication for the patient that are waiting for a liver transplantation in the phase before the transplantation, to give the best condition of this patient to come to the transplantation, but we have indication after the transplantation when we have some problem of the graft, of course. There are several different possibilities to use the extracorporeal support. We have the plasma exchange, we have of course the cyto, so that there is a whole blood absorption, the double plasma molecular absorption, or the circulation system. And we have some papers that say that the hepatic encephalopathy, of course, is a big problem, because can give to your patient the brain edema and the brain blooding. So it's a big problem. If you have a system to reduce the possibility of encephalopathy before the transplantation, it's very useful, because as we can see, there are some papers that say that the pre-transplantation encephalopathy correlates with the neurological status after the transplantation. So if I reduce the encephalopathy before the transplant, I have a better situation after, because if I have a neurologic dysfunction of this patient stays in my ICU more time, more ventilated, with more complications, and it's not a good thing even for immunosuppressive transplantation. And we have some papers that demonstrate that the use of ACLS improves the neurological recovery of this patient after the transplantation. There are a little signal in which we have in this review demonstrated that the use of the extracorporeal support reduces the mortality of this patient, of course. And we have a big indication in which patient, more in acute or chronic liver failure. As you know, this patient has a little possibility to go to the transplantation, because they has alcoholic abuse active, and so other situations in which they cannot go to the transplantation. So you have to find a therapy to regain and to bridge to the recovery of the native liver, of course, because they cannot go to the transplantation, of course. And so we started with Mars, that is the first extracorporeal liver support in 2008. in which we demonstrated in Rostock in Germany that the use of this machine reduced the mortality of this patient with acute failure. And we see the difference in mortality, of course, using this, oh sorry, oops. Okay. The difference in mortality with or without the use of extracorporeal liver support in Scandinavia, and so we see that the use reduced the mortality. We have to remember that in all kind of liver surgery, the hepatectomy, but even the transplantation, we have induced ischemia and perfusion problems. So we have a lot of pro-inflammatory protein and cytokines that are not good for this patient and for his graft. So what we have to do, ACLS, that's extracorporeal support, is used to reduce these cytokines and this inflammatory system of the patient, to allow your liver to regenerate, in particular after the hepatectomy, because the energy of the liver is not used to the function to eliminate the toxin, but only to regenerate, because with your machine you eliminate the toxin that the liver not do. There are another papers very interesting in which they have said that after the transplantation the free DNA in the blood of the patient correlates with the problem with the graft and the patient. So the patient with high level of free DNA that comes from apoptosis and from cellular damage of the liver has more problems of graft and of a patient. And if they use the absorption and with the cytosol filter, reduce the quantity of this free DNA and demonstrate that in this patient there are less problems of the graft and on the patient. So removing this inflammatory process is useful to get a better survival of the graft and on the patient. Sorry, I go away. So the rationale of the use of this system is to detoxify the liver, to help the liver with detoxification and leave the liver to use its energy all to regeneration, and not to use to the function of detoxification that you make with your machine outside the patient, of course. The aim is stabilization of the patient, bridge or to recovery if you don't have the possibility of the transplantation, otherwise to get the patient to the transplantation in the best condition possible, of course. The history of this system starts from Mars, then from Prometheus, then CPFA and singular pass albumin to 2015 with this cytosorb. There are different, yes, because the first machines use a filter that separates the plasma, and then the plasma has been filtrated to purify the plasma, and then the plasma comes back to the patient. Otherwise, the cytosorb is the only one. This cartridge is put on your extracorporeal system, and you absorb the whole blood. You don't need to separate plasma from blood. The other machines has a duration of treatment more or less 6-8 hours, and the cytos is completely different because we have this cartridge that is made for polystyrene and dibenzene copolymer spheres. There are many spheres in the cartridge with a contact surfaces more or less 40,000 square meters. So it's a big surface. Can get the exchange with the blood, with the toxin, of course. It's easy to use because it's not a machine. You put your cartridge in your, for example, CRT, the continuous renal replacement therapy. Otherwise, you can use with the machine of hemoperfusion. It's a pump that pump blood through the filter, and you have to do the absorption by the filter. So it's very easy to use. In our experience, we use the anticoagulation with calcium citrate, not the heparin. That it's very effective to maintain the life of these filters, of course. And this is the spectrum of absorption of the cytosol can absorb molecules, hydrophobic molecules, till 60 kilodalton of the molecular weight, of course. So that the filter doesn't absorb albumin, that is crucial, of course. It can absorb cytokines, bilirubin, bile acids, or the inflammatory proteins that are in the patient. That is not useful in that situation. We use, in our experience, to understand if it's effective treatment, the mass balance, because if you read in literature, you find out many papers in which they say that it's not useful because we have not efficacy of this treatment, because they consider the removal rate, how much the cartridge remove in a single moment. But you have to remember, for example, for bilirubin, that you remove bilirubin from the blood, but you have in a jaundice a lot of bilirubin linked to the tissue of the patient that comes back to the plasma. And so the useful of these machine instruments, you have to evaluate in how mass balance you extract from the patient, how much total bilirubin you extract from the patient. And so we have done our study in our ICU. We started in 2008 to use this kind of machine, and in our study we demonstrate this situation in which the use of cytosorb is, we observed 5 times higher extraction, absorption than the other machines. So it's very effective as mass balance to extract from the patient and purify the patient, of course. We observe the extraction go on to 24 hours. There is a maximum use of one cartridge compared to the other machines. Of course, the treatment duration is crucial because, of course, the other machine, each treatment has lasting more or less 6 hours. Otherwise, the cytosol can absorb till 24 hours. So it's much continuous, more continuous than the other machines. Probably it's a factor that affects the better removal performance of this cartridge. This is another demonstration compares to Mars. The dark gray is the Mars, the light gray is the cytosorb, and the extraction is higher with cytosorb than with Mars. This cartridge can extract even the albumin-bound protein, so can extract the total bilirubin, even the direct, the conjugated, even unconjugated bilirubin. That is very important because we have a global extraction of bile acids, amphoricals, and bilirubin. We don't observe any rebound of molecular molecules, so the molecules extracted don't come back to the patient even after 24 hours, and the extraction go on even at the 24th hour of treatment. Otherwise, not the same situation in the other machine, of course. As the colleague of Spain colleague before, even in Italy we have a bad situation in which we have to wait 20 minutes to certificate the death of a patient. So we started to use DCD patient, even in Italy, of course, but we had the problem that we have to wait 20 minutes after the cardiac arrest to start the perfusion. That is unbelievable, but it's the situation. So we use, even in Italy, the perfusion of the graft after you extract the graft, the liver from the donor. We put with the machine of the perfusion that can perfuse the liver up to 6-8 hours. And we use this perfusion even in the graft in which we are not so sure that it's fitable for the transplantation. To, of course, have more graft to transplantation in a historical moment in which the transplant are not so good, of course. And we started even to use the double sequential perfusion with this Italian machine. We start with hypothermic perfusion, then we arrive to normothermic perfusion, and then we can transplantate the graft to the patient. And it seems that it's better, the situation, than the other. And is ongoing even another study in Bergamo, in which we put the cartridge of cytosol in the perfusion machine. The aim is to remove the cytokines from the graft before the transplantation, to reduce, of course, the quantity of cytokines or inflammatory cytokines that can come to the recipient after the transplantation, and it seems to give good results. Our experience, and going to end, in Bergamo, more or less we perform 100 liver transplantation per year. In Bergamo we transplant all kind of organ, adult and pediatric, gut, liver, kidney, heart, and so on. And more or less our mortality surviving any year is more or less 90%. We started in 1997 with the first liver transplantation, and up to now the historical survival rate is more or less there in 90%. So the conclusion, all these treatments are of course effective in removing bilirubin and bile acids. There are substantial differences in the duration of the treatment of all these techniques, of course. The adequate anticoagulation is essential to use this kind of treatment, and the indication is for all the liver failure, acute or chronic, pre and post transplantation. We have to evaluate, of course, the efficacy by the mass balance. In particular, cytosol is very easy to use because you put on your dialysis machine. So you need a shorter training of physicians and nurses, of course. You can use with any type of machine, even hemoperfusion with a blood pump. We observe no release molecule after the treatment to the patient. We demonstrate with not significant loss of albumin or platelets during the treatments. And we demonstrate even the removal of albumin-bound protein molecules, as stated before, for example, for the bilirubin. And so, the future issues. Of course, as in evidence-based medicine, we need the probably randomized control trials to understand the benefit of this kind of treatment, of course. But the problem is that the compare is to standard medical therapy. But are we sure that all over the world the standard medical therapy for hepatic patient is the same? I don't think so, because if you stay in a transplantation center is one thing, if you stay in a peripheral hospital is another thing, of course. So the comparison is not so easy. And probably we have to evaluate the benefit in the different subgroups, of course, because the pathophysiology of acute liver failure is completely different from acute liver failure, in which it's inflammatory. So it's better to study all patients with ACLF, all patients with acute liver failure, all patients with transplantation, to understand the real benefit of this kind, of course, of treatment. And the conclusion is the timing, because you have to use not for all patients this treatment, of course. You have to choose the right patient, but you have to choose more the right time in which you use this kind of treatment. Not too soon, not too late, in which the patient is over the point of no return. So, in our experience, we can say that our treatment is useful, and in the hepatic patient there are another possibility to treat with benefit these patients that are not so easy to treat, of course, with transplantation, but more without transplantation. Muchas gracias.